everyone. Did you have a nice lunch? Yeah, hopefully nobody's going to be in a food coma in the next 5 minutes, right? Okay, so my name is Carrie Espinosa, and I am the principal advisor at Horizon Benefit Services. It's my little company. I got a team of folks that help me serve the community. We are a hire-to-retire solution, and why that's important is because we work with employers who are offering benefits for their employees, Affordable Care Act, and other individual health options in Medicare. And what I've discovered is that it's all symbiotic, it's all interrelated. Medicare is a driver for a lot of other health insurance markets. My office is located in Northern Illinois. I'm licensed in Illinois, Wisconsin, and a few other states. And at an earlier session, there was discussion around healthcare literacy, or health literacy, right? 12% of the population. That's my why. My why is because I get it. And not just as somebody who helps people with health insurance, but as a healthcare consumer myself and as an advocate for my grandmother and all of my clients. And I think it's important that we, frequently revisit our why and not let ourselves get burnt out in this industry, right? Well, let's talk about Medicare. And we're going to start with the big picture. From there, we'll talk a little bit about the history of Medicare, where we're now, the future, and how to effectively navigate the Medicare landscape. So this is sort of an overview of our population, or our little road to retirement, right? We go from being covered under our parents' plans to having our own health insurance, whether it's through an employer or an individual, and then Medicare before we ride off into the sunset. Medicare currently accounts for about 65 million beneficiaries, which is 25.4% of the population. Employee benefits account for 55% of the population, and 10% of the population has to go out and get their own health insurance. So if you do the math on that, we're at like 90%, right? Yeah? Was everybody agreeing with me? Okay. Well, the rest of that that accounting is folks who are either covered under like TRICARE or Health Share Ministry or Medicaid, or they're uninsured. So I believe in setting the table, and I'm going to have some food analogies today, but we're going to start with setting the table. And I want to just take a walk back in time, right? During the Great Depression, the elderly were not just quite dependent, they were absolutely dependent on their children for support. That meant medical, financial, caregiving. Can you guess, even back in the Great Depression, how health care was obtained? Did people have health insurance? Some people did. Some people bartered, right? Trade your horse for delivering my baby, doc. It was obviously a long, long time ago. But having lived through the Great Depression, it made the politicians in the country realize that we needed a little bit of a different solution. And while President Truman is credited with actually the, while I get my glasses, with the first official attempts to get a federally funded health program off the ground, it really started with Franklin Delano Roosevelt. FDR was the 32nd president and was responsible for passing the Social Security Act in 1935. Social Security Act of 1935 was a financial safety net for the elderly, unemployed, and disadvantaged Americans. Now, do you remember, and I'm just going to go back real quick, this is President Truman. He was the first one who made the first official attempts to get the federally health-funded program off the ground. But it started with FDR, right? Do you remember why it was not part of the Social Security Act of 1935? Think of the world in 1935. We were post-war, post-depression. The thought of having a Social Security program along with a Medicare program was too socialistic for our country at that time in place, right? So we didn't get a lot of traction, and it took some time and some coercing before we were able to progress to getting into a Medicare program. It was actually on July 30th, 1965, that President Lyndon B. Johnson signed Medicare, a health insurance program for elderly Americans, into law. I want to pause for just a minute and not forget to recognize the Kerr-Mills Act of 1960, which was sort of the predecessor. It was Medicare-ish, but not completely Medicare, and had more of a Medicaid feel to it. When 1965 rolled around, there were only a couple 100,000 people enrolled in the Kerr-Mills Act program. It was managed by the states. And so 1965 is when the official Medicare program came into being. Can anybody guess in 1965 how many people started participating, got enrolled into Medicare? No guesses? No? All right, how about 19 million? 19 million people were enrolled in Medicare in 1966. My great-grandparents, it's so crazy, you stop and you look back in life and you think about things. My great-grandparents were born in 1900. They were the first population to be onto Medicare. And I want to step back real quick to this slide because going back to the Depression, if everybody noticed, how many kids were there per woman in the U.S.? There were 8 children per woman in the U.S. back in the 1800s, and now we're down to 1.93. But that's going to be relevant as we continue this conversation about Medicare and about funding and about the future of Medicare. So 1972, Medicare was expanded. It was expanded to include end-stage renal disease, people who are under 65 and disabled. And then 2003 are when the next big changes are coming to Medicare, right? Medicare Part D. So in 2003, President George Bush signed into law the Medicare Modernization Act, which added outpatient prescription drug benefits to Medicare. Do you guys remember your parents having Medicare and not having prescription drug coverage? No? Some of us, yeah. How did they afford their medications? Nobody? No? Yeah, maybe they did, maybe they didn't, right? So 2003 rolled around and President Bush introduced the Medicare Modernization Act. It also came with the CHIP Act. CHIP is the program for the kids, the Children's Health Insurance Program. And that was part of the MECRA, the Medicare Reauthorization Act. And it changed how Medicare supplement plans, operated in 2020. So going back into time, right, we have 1935, Social Security is introduced. 1945, they start proposing national health care. Well, they tried to do it in 35, but we were, post-war, post-depression. Nobody was hearing it. 1960, Kerr-Mills Act, which was sort of the precursor for Medicare and also a precursor for Medicaid because it focused on the low-income folks. And then 1965, Medicare passes, 1972. Then we're at 2003 with Medicare Part D, and then 2020 with MACRA. It's important to know, too, in 2003 when Medicare Part D was introduced, approximately 19 million people enrolled. 19 million people. And that wasn't all of the Medicare population. That was a big percentage of it, but some people continued to go without the Medicare prescription drug coverage. 2003 again, right? We've got the Medicare Modernization Act, which is the voluntary outpatient prescription drug program. It also subsidized premium and out-of-pocket costs for beneficiaries with incomes below 150% of the Medicare, of the federal poverty limit with limited assets. Has anybody heard of Extra Help, the Extra Help program? Yeah, it's wonderful, right, for the people who qualify. It was actually expanded again, not that recently. And I apologize, when this got converted from Canva to PowerPoint, it seems they've done a little quirky things with the formatting. So the Medicare 2020, the Medicare Access and CHIP reauthorization, what that did was it said, hey, for those folks on Medicare supplement plans, you can't have a Medicare supplement plan with no out-of-pocket cost. And we'll talk in just a minute about what that means and what Medicare covers and what supplements cover. But essentially, prior to 2020, folks who were eligible for Medicare could purchase a Medicare supplement plan, a Plan F, that had zero out-of-pocket costs. Now, folks who are still eligible for Medicare prior to 2020 get to keep that. It didn't tell them that, no, they can't have that anymore. It just said beneficiaries who were new to Medicare starting in 2020 were not going to be able to now purchase the Medicare Supplement Plan F or the high deductible F or the Medicare Supplement Plan C. When I got in this industry back in 2003-ish, when I was 15, in case anybody's asking, it was interesting because there was a Medicare Supplement Plan J that was retired not long after that. Did anybody ever experience a Medicare Supplement Plan J? Yeah. There's like a few remaining, probably 10. It's like those authentic gold coins, right? That if you get one of the 10, you're rich. But they're not available to folks anymore. MACRA, interestingly, also changed the way in which providers are compensated. So it required a sustainable growth rate formula, creating annual physician payment updates in the initial years in 2019, and it bases physician payments on two payment tracks known as merit-based incentive and the alternative payment models. If you were working in the home health care industry or working with the elderly population in home health care at any capacity, 2020 was a big deal because it changed how home health care providers, right, were compensated, and it made it more difficult for them to provide the same quality of care and receive the same level of compensation. As we go through this discussion, it feels a lot like Goldilocks and the Three Bears, for my opinion. Porridge can't be too hot, porridge can't be too cold, it has to be just right. And I feel like they're doing this on the Medicare regulatory side as well as the provider payment side. And I'm not here to say that they're pushing us into a single payer system, but boy, if you step back and you look at things, you're like, if the porridge can't be too hot or too cold, we're not going to be left with too many options. So let's talk about where we are today in terms of Medicare legislation and the Inflation Reduction Act. And we're going to dip our toes in the water for just a minute, and then we're going to hit pause and talk more about just Medicare in general. So President Biden signed the Inflation Reduction Act into law back on August 16th, 2022. It was designed to help meet climate goals as well as benefit many vulnerable populations. Did anybody know about the climate goal agenda with this? No, we all thought it was just healthcare related, right? What I found in my tenure as the legislative assistant for my association is that a lot of times when bills are passed, they're titled something really clever and witty, and it makes you think it's doing one thing, and then it does 10 other things over here that you don't even know about until it's like too late, right? So the goal was for Medicare to improve in several ways by lowering drug costs, expanding benefits, stabilizing the prescription drug plan premiums, et cetera. So it started with picking some drugs. Maybe you guys have seen the list of medications that were chosen, but it allowed the federal government for the first time ever to go and negotiate the cost of drugs. So if you're anything like me, you're sitting back and you're like, well, wait, in 2003 when they introduced Medicare Part D, they weren't negotiating? They weren't negotiating. Does anybody know why? Because of lobbyists, because of the pharma industry, right? And I know we've got a lot of the specialty pharmacy folks here today, and they're advocates, and they're great, and we appreciate them. But let's be honest, healthcare is very profit-driven, and when things are profit-driven, it changes the way things should work sometimes. So then there were negotiations allowed between HHS and drug manufacturers. The negotiation ended. The maximum fair amount was actually just recently published, and the negotiated prices will take effect in 2026. Now, is it good that the government's, and this is Carrie's opinion, obviously, right? Is it good that the government's negotiating this? Heck yeah, I think everything should be negotiated. I think there's supply and demand, right? And there's what I'm willing to pay for something and what I want to pay for something, and it's not a bad thing. Interestingly enough, if you go and you Google top 10 lobbyists in 2022, of the top 10 for in healthcare, pharmacy, healthcare, insurance. So it just talks about how big of a force our healthcare system is. And when I say healthcare, I mean healthcare providers, doctors, therapists, pharma, right? It's very complicated. So here's a little bit about Medicare, and I think this is important and part of like the dialogue about where we've been, where we are, and where we're going, is where are we now and what is it doing, how does it work? So Medicare is, original Medicare is a 1965 version of Medicare. It has two parts, Medicare A and B. It's funded through a combination of taxes deposited into trust funds, beneficiary monthly premiums, and additional funds approved through Congress. In 2023, there was an employer-employee match. So I own an insurance agency and I have employees. And when we do payroll, there's a Medicare line item. When you look at your payroll, if you work for a company, there's a Medicare line item, right? Medicare, Social Security, all of that. A lot of people don't realize, and I sure didn't realize this when I was working for someone else, that my employer was also matching that. So remember that slide where we went back and we said there were 8 children for every woman in the 1800s, and now we're down to less than 2. The fewer workers we have, the more impactful that's going to be on how our system runs and how it's funded, right? If it's partially funded through payroll taxes. Medicare has 65 million beneficiaries, 905 billion in expenditures. It's the second largest social insurance program in the U.S. Can you guess what the first is? Social Security. Yep, Social Security. And back in 2003, they were saying the Medicare Trust Fund annual report said it was only going to be solvent through 2031. It's now been updated to say it's going to be solvent through 2036. I don't know what y'all feel in this room, but that's still too close for me. I want to hear like 3,000. I don't want to hear 2030 anything because it makes me nervous, you know. And the older I get, the more nervous I get. So let's talk a little bit more about original Medicare, right? We know how it's funded. It's funded through payroll taxes. It's funded through the general fund. Medicare Part B, by the way, is funded by premiums. When somebody enrolls into Medicare Part B, they pay a monthly premium. Not only is Medicare not free, guess what? It doesn't cover everything. And if this is the first time you're hearing this, I want to say good. I'm glad that you're hearing it before you need to hear it as a Medicare beneficiary, because there's nothing more challenging than being in my position, sitting across the table from somebody and saying, yeah, so we need to get additional insurance. We need to talk about how to mitigate these out-of-pocket costs. And people say, what do you mean? I thought at 65 it was all going to be easy. And yeah, no, there's nothing going to be easy about it. So Medicare has gaps. It has deductibles, it has co-payments, and it has co-insurance. Are there any folks here from Wisconsin? Okay, you're going to, oh, my analogy didn't work. I had a little piece of Swiss cheese that was supposed to zoom up in here. Darn it. Okay, so if I live like literally 5 blocks into Illinois on the Wisconsin border. I like cheese analogies. So when you think of Medicare, and this is what I tell my clients when I'm sitting with them, and I'm like, hey, you want to know what Medicare's like? And they're like, what? A box of chocolates? I'm like, no, it's like Swiss cheese. There's gaps in Swiss cheese. There's gaps in Medicare. And as healthcare consumers, right, we have choices. We can say, okay, well, you know what? I'm all right with that. I'm okay with the gaps, and I'm willing to pay the out-of-pocket cost. Or we can say, no, I want to mitigate some of that exposure. So what does mitigating that exposure look like? Mitigating that exposure looks like a couple ways. So this is from the Medicare and You Guide, by the way. only Carrie enhanced it just a little bit because in the Medicare New Guide, they only have original Medicare with a supplement and a drug plan or Medicare Advantage. I added the third row over, and again, I apologize, this didn't convert well from Canva, but it's Medicare Advantage plans that are also provided by employers. I put them in a different category than the Medicare Advantage plan that we can go and buy on our own. And then there's also VA benefits and TRICARE for life, right, and Medicaid. So I want to focus on the first two columns, on the Medicare supplement plus prescription drug coverage or the Medicare Advantage plan. So think of this as like, hey, we're going from I don't know, here to the airport. There's a lot of different routes that we can take to get there. So think of this as, hey, I'm going from where I am to destination healthcare, and there's different routes I can take. With a Medicare supplement plan, remember that Swiss cheese analogy? Medicare supplement plan actually fills the holes in the cheese. I can't remember who the young lady was this morning at the presentation who was talking about the Medicare alphabet soup, the A, B, C, D, E, F, G. That's the Medicare supplement soup, A, B, C, D, E, F, G. Actually, it's letters A through N, standardized. But Medicare supplement plans fill the gaps in original Medicare. That's why they're also called Medigap. And then we have Medicare Advantage, which is Medicare Part C, where you take that Swiss cheese Medicare card, you hand it off to a private health insurance company, and you say, hey, insurance company, I want you to manage my Medicare benefits. And I want you to give me the same or better than what I could go and get on my own if all I had was Medicare A and B. Okay, so do you understand the difference? With Medicare Advantage, there's still out-of-pocket costs because there's out-of-pocket costs with original Medicare. You have a private health insurance company just managing it. Or maybe that private health insurance company is charging you so much premium up front that you don't have any out-of-pocket costs. But there's still a shift in who manages the Medicare. With original Medicare and a supplement, you can expect to pay a monthly premium to have little out-of-pocket. With Medicare Advantage, there's all different types of flavors. But the biggest difference between supplement and Advantage is with Advantage, you're going to have an insurance company that drives your care versus original Medicare. So my grams last July, was in the hospital. She almost died. And my grandmother raised me, so I feel, like a huge indebtedness to her, and advocated through the hospital with her and fought with security when they tried to make me leave. Kidding, not kidding. But so while Grams was in the hospital, we lived by the border, she went to Froedtert Hospital, who transferred her to Aurora, which is the best heart hospital in Milwaukee. Which, going from one hospital system to another isn't common these days because they want to keep you in their system. While Graham is going through that, she went in on a Saturday, came out on a Friday, or went in on a Sunday, came out on a Friday. It was pretty seamless. While she's going through that, my girlfriend Bonnie, who had a Medicare supplement plan like Grandma, decided to give it up and go on Medicare Advantage because she's like, Carrie, why am I paying all this premium? I just want to have something that's cheap, it's affordable. So Bonnie went on Medicare Advantage. Bonnie's calling me because she was diagnosed with cancer. She's in the hospital in Chicago. And the insurance company has given her the approval to get a medical transport from the hospital to the skilled nursing facility, right? So with Medicare Advantage, there's that second letter of checks and balances, whatever you want to call it, authorization that's required. Now, does that mean Medicare Advantage is bad? Absolutely not. And I will never be one to stand up here and say that. Two different ways to get to the same destination, healthcare. Not everybody can afford a Medicare supplement plan. Not all providers take Medicare supplement plans. We have a whole medical group in our market called Dooley that some of the providers only take Medicare Advantage. So know that there's no one size fits all. But as we're talking about the future of Medicare, right, and where things are going, let's talk about how the scales have tipped in recent years. A few years ago, I would have been having this conversation saying we're at 52% Medicare supplement, 48% Medicare Advantage. Today I'm standing here saying we're at 54% Medicare Advantage, 46% Medicare, right? Maybe with a supplement, maybe with Medicaid, maybe with something else. But there's been a shift. And part of that came out of the I think it was the 2003 legislation with Bush, that's where they named this Medicare Advantage. There was a whole new shift when he when he introduced the Medicare drug plans to change the Medicare Advantage name and make it more enticing. So here's what the Medicare Advantage landscape looks like. We've got 5 minutes, so I'm just going to kind of button this up. Why are these plans so darn enticing? Because you get extra benefits, right? You get all these extra things like dental, vision, hearing. They wash your car on Thursdays. Just kidding. But you've seen the commercials. So here's the enrollment projections. Which way are they going? Up. Medicare Part D, we're going to go back real quick to the recent legislation, the Inflation Reduction Act. So this year, right, we have different drug plan coverage stages, including a donut hole. Everybody loves a donut hole? Yeah. So starting next year, there's not going to be a donut hole. There's going to be a $2,000 cap on all medications, all Medicare Part D medications. Some of the other changes that came with the Inflation Reduction Act is limiting the Medicare drug price increases due to inflation, capping the $35 copayment for insulin, expanding LIS, low income subsidy, to 150%. And then here we have how. It's because who pays for it is shifting. We're shifting from a scenario where the government subsidizes to where the insurance company is going to be more responsible. But wait, there's more. The insurance companies filed their plans for 2025, and I think CMS kind of got scared. We have some carriers like Mutual of Omaha who are completely leaving the market. I think they saw rates go up considerably, right? You can't shift costs and not expect the fundamental cost to increase. So CMS released last month or end of July Part D subsidization and premium stabilization demonstration. So it just said, hey, everything that we just did, we're going to undo it temporarily. I don't know if they undid it because it's an election year, because it was the right thing to do and it's going to stay. All I know is I'm tired of legislation. Big thing here, Medicare Part D layaway. Does everybody remember going to the Kmart when you were a kid? Putting your stuff on? Yep, and you were going to get it after you paid it off in 2 months. Yeah, so now we're going to do that with Medicare prescription drugs. Take that $2,000 maximum price. Say you're on a drug that's $100 a month, $1,200 a year. You can finance that now through the Medicare drug plan. I bet the pharmacists in the room can't wait. Nancy, what say you? So just as we close out, right, the number of Medicare beneficiaries versus the number of workers, somebody's got to pay for it to work, right? We have fewer workers, fewer people paying in. We have fewer births, you know. Don't hate the player, hate the game. And then Medicare spending. One more thing I want to say real quick about Medicare Advantages. 22%, Medicare Advantage costs 22% more than private fee-for-service Medicare. So there's got to be something more to it, right? Why are they driving that? In Carrie's opinion, it's to get control. How long can we continue to kick the financial can down the road? I don't know. They've been doing it a really long time. What's the solution? Increase taxes, decrease benefits, or a combination of the two? Who likes any of those? Nobody. And whoever's in office at the time, I don't care what party they are, political suicide. Last thing I want to say is there's a lot of scams. There's a lot of ways people can enroll in coverage. Can anybody believe this? Medicare.gov is not funded by government employees. Maximus Federal Services owns the contract for that. I was shocked when I found out. I found out on accident. I called for a client, and I was like, by the way, who are you? And after a little chit-chatty, I found out that they were a third-party vendor. So in navigating, this is just real quick. These solicitations, you guys, that your clients are getting, your parents are getting, are horrible. They look official. They look scary. Please, 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 measure twice, cut once. So here's what I'm going to leave you with. Know the difference between original Medicare and Medicare Advantage. Know that when you're looking at a plan, it's your docs, your drugs, and the deets that matter. Deets being details. I don't want to be too sus up here with my kids around. Just kidding. And then consider your healthcare priorities, right? Not just today, but in the future. Know what's covered and just as importantly, what's not covered. Health insurance is really just a funding mechanism for healthcare. I know that we come to these conferences and I get a little fired up too, and I'm like, those darn insurance companies. And then I'm like, wait, if I could afford a heart attack, I wouldn't need my health insurance. So, common denominator, right? Find a professional, make friends with an insurance professional because they can be a great resource. And beware scams. Thank you. And I'm sorry I didn't allow time for Q&A, but you can catch me outside. Didn't somebody say that?